on to the neurologically based communication disorders. So this is a little bit different from our childhood language disorders, where the children are typically born with the language disorder, or it happens very close to birth or in childhood before language development can really occur, into more of our adult population where there is an established language function, there's an injury to the brain, and then they have a decline in their language abilities. So this is chapter 10, page 315 through 330, because today's lecture is only going to focus on aphasia. So what we'll start with is just an overview of what neurologically based communication disorders are, and then we'll specifically go into aphasia, the causes for aphasia and the brain-language relationship, the different types of aphasia, and how we assess and treat. So neurologically based disorders are just those that are associated with a disease or trauma to the brain. Usually it's within the cognitive and language areas of the brain. It can also be those that affect swallowing, so those sensory or motor areas, anywhere in the cerebral cortex as well as the cerebellum, the brainstem, the cranial nerves, things like that really involve those neurologically based disorders. The onset for neurological disorders can be congenital, meaning it happened before birth due to some type of injury, or because of a genetic issue, or it can be acquired as a result of after birth and an injury that's acquired later. So we talked about these two before already in childhood language disorders, but really we're really going to focus on the acquired, more so in adults for this lecture. That doesn't mean that aphasia or brain injury can occur in children. It's just that we're going to focus more on this in the older population. There are also two different ways that neurologically based disorders can progress. So there is a degenerative type of neurological disorder, which means that its symptoms progress over time, or the disease process progresses over time or worsens. There's also the non-degenerative, which means that it's relatively stable. So there's not an ongoing injury to the brain, there's not a decline within the function, it remains pretty stable, it can improve. So this, again, we're going to focus only on aphasia today. There are other types, but we'll talk about those in the next lecture. So aphasia is an acquired non-degenerative language disorder. So that means that it happened as a result of injury to the language centers of the brain, and then it's non-degenerative, so it does not progress or worsen over time. Now, aphasia is classified according to its characteristics. So we're going to talk about the different types of aphasia in just a little bit, and you'll read about them in your chapters. But you have to keep in mind that the symptoms may not fit a single type of aphasia in a real patient. So we'll talk about the brain language relationship and how everything is kind of interconnected. And so you might have a little bit of an issue that doesn't fit a true aphasia type in patients because of how the brain interacts. And then again, classification can change with recovery. So as these patients progress, they may have deficits initially that improve over time, and so it may not fit that perfect picture of the certain classification. Ultimately, aphasia is just an impairment in the ability to understand, formulate, or express language. It affects only language, but it doesn't affect intelligence. So the person is just as smart as they were before they had the injury. They just have difficulty communicating. So there are different causes for aphasia. These are a few of them. It could be a stroke, meaning that there's a blockage in the blood flow in the brain. It could be a traumatic brain injury where something injures or shakes the brain or enters the brain. It could be a tumor where there's putting pressure on a certain area of the brain, epilepsy or seizures, meningitis or swelling of the brain, encephalitis, surgery accidents. That could be accidents during brain surgery, or it could be as a result of surgery to other areas. Either the patient develops a clot as they're on the table, or a clot becomes dislodged during that surgery, or there's damage due to devices or things like that. It could also be a result of bacterial or viral infections. The most common cause of aphasia is a stroke, and this has to do with the risk factors for stroke. So there are more risk factors, being diabetes, high blood pressure, genetics, different things that make it more likely that a stroke is going to occur versus all of the other causes of aphasia. Now, a stroke typically occurs more often in the language-dominant left hemisphere, but it can occur in the right hemisphere. But the language hemisphere is more often in the left, except in 3% of the population it's on the right side. And so you don't hear about those as often, but it doesn't mean that it doesn't happen. So the different types of strokes are cerebral arteriosclerosis, which means that there's a hardening of the cerebral arteries. So if we think about an artery as a path for blood to flow through, and you want a nice open path so lots of blood can get through and lots of oxygen to the brain. Over time, those walls harden and plaque can grow, narrowing that circle, and so less and less blood can get through, and ultimately it can result in a complete lack of flow of blood. And that's when you have a stroke. You can also have an embolism, which is a blockage in the flow of blood, either as a result of plaque or some type of foreign substance in the blood. There's thrombosis, which is a blood clot that blocks the blood flow. You can also have an aneurysm, which means it's like a balloon in the walls of the artery where there's a weak spot and that area bulges out. Some people can live with an aneurysm and not know that they have it until they have a hemorrhage, meaning that that balloon bursts and all of the blood flows out onto the top of the brain and is no longer traveling to the areas it needs to go to, but is also putting pressure on the brain because of that blood building up. So all of this is important because of the neuron pathways. So we've talked about Wernicke's area and Broca's area and how these two areas communicate along with the motor strip and the sensory strip. And essentially what you have is this communication pathway so that you have branches of neurons that can give you sounds for words, how to put those sounds into words, how to put those words into sentences, and then making those muscles, your speech muscles, move to produce the sounds and shape those sounds. And then you also have the pathways for hearing. And because of a stroke, those pathways are essentially cut off. So this is, a car accident on I-12, and it shuts down the whole interstate. Well, since you've had a stroke on I-12, you've got to find a way to get around to your goal, your target, where you're trying to go shopping, right? And so what happens is the blood and that information is trying to reroute and get its way around this accident on I-12, but it can't quite get there. And so you have a breakdown in the way that a person communicates or in their language skills. And where that breakdown occurs, where it happens on I-12, depends on the type of communication disorders or language disorder you're going to have. So we've talked about a few of these areas, and I'm adding just a couple extra ones so that you can see that it truly is a pathway. So we have Broca's area that gives us our motor programming for articulation. And remember, once you know the function, you can figure out the dysfunction. So if we have that motor programming for articulation and there's an accident on this highway, then you're going to have trouble with articulating. Now, Broca's area is near the motor strip, which is responsible for activating the muscles for articulation. So you're likely going to have an accident somewhere in this area and more trouble with articulation. The arcuate fasciculus transmits linguistic information from areas, the front areas to the back areas. So from Broca's to Wernicke's. Then we have Wernicke's that gives us the comprehension of oral language, so this is our auditory comprehension. Then we have the angular gyrus that integrates all of our sensory information, and that's really important for our reading abilities, right? Bringing in our visual information and our ability to identify letters and putting those letters into words and words into sentences. And then we have the supramarginal gyrus, which is for integration of writing. And then we have some subcortical areas we haven't really talked about, the thalamus, the basal ganglia, things like that that are important for language and speech. So all of these areas communicate. We have pathways between each of them, and all of those pathways come together to give us our speech and our sounds, our voice, our words, and our sentences. what we're really going to focus on more so is in the lobes. So these are our big areas, right? We have the frontal lobe overall is responsible for speech production because it houses the motor cortex and Broca's area. We have the parietal lobe, which houses the sensory cortex and the integration of any type of sense or touch or pressure. We have the occipital lobe, which is responsible for vision. It houses the visual cortex. And we have the temporal lobe, which houses the auditory cortex and Wernicke's area, and it's important for language comprehension again. If we have damage to these areas, then we have problems in communication. So this is pretty straightforward. If there's damage to the frontal lobe around Broca's area, they're going to have Broca's aphasia. And so we know that that function is speech production, so people with Broca's aphasia will have trouble with speech production. Then in the parietal lobe, this is incorporating sensory information. And so if people have damage to the sensory cortex or around it, then they're likely going to have trouble reading and writing or integrating the sensory visual information. And then there's the occipital lobe. If it's damaged, then you have trouble identifying what you see. So naming objects that you're looking at or understanding when someone describes an object what it is without seeing it. And then we have the temporal cortex with Wernicke's. It's responsible for language comprehension. If there's damage, they have Wernicke's aphasia, and so that person has trouble with auditory comprehension. When we're classifying aphasia, it can be classified either as a single disorder or as several different types of disorders. So there's two viewpoints, which the first one says there's only one type of aphasia and we just have different characteristics. So mostly all of the aphasias are going to have trouble with speaking, understanding, reading and writing, using their gestures to some extent. And they might have additional problems, whether it is paralysis or trouble writing or trouble seeing, trouble hearing. And the theory is essentially that all of those areas are interconnected, and so if you have a stroke, it's not going to land, boom, exactly where you need it to land to give you Broca's aphasia. It's going to land somewhere around it. So you might get a characteristic of everything, and it's specific to that person, but essentially every area is going to be impacted. Then we have the second view that says, no, we can really subdivide types of aphasia into categories. And so the big overarching categories are fluent and non-fluent, but it can be broken down even further. So fluent essentially means that you have fluency in speech. It's very fluid, meaning that it continues, it doesn't have pauses or breaks, it's effortless, and it has intonation or rise and fall in the pitch. Versus non-fluent, meaning that it's very broken speech, it's missing some very important features of speech, whether it's grammar or sounds or information. It's effortful, meaning the person is really working to get that information out, trying to think of the words and put them together. And so we'll look at it more so in these ways for the remainder of the class, but first we're going to talk about just the different types of characteristics that a person can have. Alright, so those general characteristics really depend on the area of damage. So remember, we have those pathways. We're trying to get to our shopping center, but our shopping center is shut down, or we're further down the interstate and the interstate is shut down. It depends on where that damage is. So a person with aphasia could have difficulty remembering words or saying the correct words. They could have trouble saying the words in the correct order or understanding or expressing gestures. They can have trouble reading and writing, or they can have trouble in all aspects of social communication and participation. When we're talking about reading and writing, it really usually mirrors their oral language deficits. So if a person has trouble speaking, they're likely going to have trouble writing. If a person has trouble listening or hearing, then they're likely going to have trouble reading. The catch is, sometimes you can access language better either through a visual or verbal approach. And so even though there are deficits in nonverbal language or in reading and writing, you may be able to access that language a little bit better versus speaking or listening. And we'll talk about that a little bit more in the treatment section. So all we do essentially as speech therapists is give fancy names to things. So we said, everyone's going to have an element of trouble with spoken language. They're going to have an element of trouble with auditory comprehension or problems with reading and writing. And now we're just going to give those nice names to them. So these are your definitions. They're pulled from the textbook. So the first one is anomia, which means that there's difficulty naming things, objects, or people. So this is essentially someone who wants a spoon, and they go, oh, I want that thing that you stir with, the thing you eat soup with, but they can't say that they want a spoon. They can also have a paraphasia. So this is a word or sound substitution, and it can be broken down into different types of paraphasias. The first is a phonemic paraphasia, and this goes back to our phonemes. So at the sound level, it's a sound substitution. So instead of saying, let's go have fun, or I'm having fun, they say, I'm having gun. Okay? And then you have verbal paraphasias, meaning that it's falling within the same category. So, for example, a few years ago, I had a patient who couldn't think of the word spoon, and she called it a cement mixer. And so it's a little bit off, but you can stir with it, right? And it could be used as a cement mixer. So that's an example of a verbal paraphasia. And then there's just neologisms. Neologisms are new words or made-up words. You're not going to find them in the dictionary. They may not even fit a true word structure. It may be something like bobbity-ba. It may be a ta-ta. It may be something completely random or complete nonsense. Paraphasias can form jargon, which means that you have irrelevant or meaningless speech. So this can be just speaking complete nonsense, where the words are out of order, or they're missing words, or they have just complete use of neologisms or made-up words, but they're keeping the fluency of the speech, or that rise and fall in that continuous speech. On the opposite side, you could have agrammatism, which means that you have omission of grammatical elements. So you're leaving out your articles, you're leaving out some of the less frequently used words. You have very broken speech. And then there's perseverations, which means that the person has the same response to different questions. So it could be that they use the same response no matter what in terms of yes and no, or other types of stereotypic expressions, or it could be that they use a made-up word over and over again for different questions or different responses. On the comprehension side, we have agnosia. So agnosia is just difficulty understanding the meaning of sensory information. So visual agnosia is the inability to name something just by looking at it. So that's holding glasses up in front of somebody's face and they can't tell you what it is. On the other side of that, there's auditory verbal agnosia, which means that a person can't recognize the meaning without seeing the object. So that might mean, Mom, go grab your glasses. And she has no idea what you're talking about. But if you have her glasses in your hand and you say, here are your glasses, she knows what that means. She knows what to do with them. There can also be difficulty with reading and writing. So there's agraphia, which is difficulty reading, and alexia, difficulty writing. Now we're going to break it down into our non-fluent versus fluent. So these are the different types of aphasia when we talk about the specific classifications. So we have global, Broca's, transcortical motor, mixed transcortical, Wernicke's, transcortical sensory, conduction, and anomia. Now, anomia is not to be confused with that typical classification or characteristic of language of anomia. You can also have an anomia aphasia, which means that you have difficulty with word finding, and that's essentially all as an aphasia characteristic. Everything else is intact. So we can see here, when we're looking at comprehension, repetition, and naming, these are the general characteristics in how we break up the different types of aphasia. So we're just going to focus on Broca's and Wernicke's for this class. Just know that there are others out there. So in Broca's, we can see that they have good comprehension, but poor repetition and poor naming. And then in Wernicke's, they have poor comprehension, poor repetition, and poor naming. And we'll go into that a little bit more in detail. So Broca's aphasia is, again, a non-fluent aphasia, which tells you that it's going to be very broken speech, but the information is going to be there. So they're going to have agrammatism, where they're missing certain words, which is going to leave them with very short utterances. They're going to give very basic information. They're going to be great at answering yes or no questions. They're going to lack that rise and fall in their voice, and their speech may look very effortful, meaning that they're either looking for the word, they look puzzled, they have frequent pauses, or they have a lot of interjections, like or overall, their auditory comprehension is okay, so they know the questions that you're asking. They're just having difficulty giving you the response. And then they have impaired repetition, meaning that they can't say the word over and over again. And then we have Wernicke's aphasia, which is fluent. So they have that continuous rate, they have the intonation, they have relatively low or no effort in their speech, but they have essentially meaningless speech, and that's because they have the paraphasias or neologism. They may use a lot of jargon. They're essentially just carrying on a conversation, but you don't know what it means. They also have impaired auditory comprehension, so if you tell them to do something, they're not going to know what that means. Or they say, you say, how's your daughter doing? And they go, I'm hot. Because they don't comprehend what you've asked them. Overall, they have good articulation and good intonation, and again, this plays into the frontal lobe is intact, the motor strip is intact, but the sensory lobe is not. Parietal lobe and temporal lobe are not. So just to give you a visual of this, we have the primary motor cortex up here at the top, right? That's very, very close to Broca's area. We have the arcuate fasciculus, which transmits that information anterior to posterior or front to back. And then we have the integration of that information between the two centers. But if there's damage up here around Broca's area or around the motor strip, then we're likely going to have good comprehension but poor fluency, because we're impacting that motor area or that speech production. And then we have Wernicke's area around the sensory strip and the temporal lobe, and so it's going to have poor comprehension but good fluency because we haven't impacted that motor strip. Alright, so next up we'll talk about assessment and treatment. For the assessment of aphasia, it's not that different from our childhood language disorders. We're still going to get a history of the client and the family or caregiver. The difference is, when we're talking about a child in school, we're asking how they're functioning with their peers and how they're functioning in terms of grades and school performance. With adult clients, you also have to think about they are caregivers. They have to provide for their children. They have to provide for their family, and they have jobs, so they have a different type of interaction. We have to see if they can continue with that job, if they can continue being caregivers, or if we have to explore other options. We're still going to do an orofacial examination. In this case, we're looking for weakness in the structures. So think about that motor strip. If there's damage to that motor strip, then they can also have weakness in that area. They can have trouble coordinating their tongue, their lips, their teeth for the movements of speech, and we have to be able to identify that. We'll also do a hearing screening because you can have hearing damage due to a stroke. And then we'll look at a speech and language sample, and there's different ways of looking at that speech and language sample. Now, we always do a speech sample on our aphasia patients because of the motor strip. So you can have deficits in speech or shaping the speech sounds in addition to a language disorder or giving the meaning to what we're saying. So in terms of our formal assessment, we're going to look at all domains of language. There's two big assessments that are out there we're going to talk about in class. There's the Boston and the Western assessment for aphasia. So we have to be able to identify what domains of language are truly impacted because of aphasia, and that will lead to our foundation for our treatment. We also look at their conversational skills. So essentially what we're looking at is where is the breakdown in the domains, where in that hierarchy are they having trouble, and then how does that hierarchy, how does that domain really impact their overall communication in conversation. So that's called a functional assessment, meaning that we're looking at communication in everyday situations. We're not giving a grammar test to see if they have good grammar or good speech sounds. We're really looking at how it impacts their ability to communicate with their family, their ability to communicate with their healthcare providers, with their friends, if they're able to read or write or plan, because that impacts their overall function in everyday situations. And then in our assessment, we also do our treatment planning. So we establish our baseline with the assessment and evaluation. We set the goals based on the domains and our goal function. So for instance, if we're working on naming items, we want to name items specific to their job, right? And if they are an accountant, then those are going to be very different words or different words that we have to name versus somebody who works in a healthcare setting. And then with our assessment, we do it continually throughout treatment. So we'll talk about in just a minute the recovery after a stroke and how that can affect our language development with treatment. And then once we meet our goals, after our assessment, we can discharge the patient. So our treatment really relies on the results of the assessment because we're looking at those different domains. We're targeting behavior specific to that individual, so that again goes back to our functional communication. And ultimately our goal is our social communication and the ability to interact with their environment. So we're not trying to keep them in a clinic room and making sure that they can name objects on a piece of paper, but it may mean that we have to start there. So we might have to start with picking up a fork and naming a fork before we get out into a restaurant and using the fork or asking for a fork. And during treatment, we have to keep in mind and we have to tell our patients that recovery is a slow process. So there is not a day that a patient just wakes up and their language goes back to normal after a stroke. It is a lot of work, it's a lot of dedication, it's a lot of time, but at the same time, there is something called spontaneous recovery. Again, it doesn't mean they wake up and everything goes back to normal. It essentially means that there is injury to the brain, the pathways are damaged, and then for the first few weeks after a stroke, those pathways that can be reestablished are quickly reestablished. And then the pathways that are remaining really continue to be worked on, but it's going to take a while. So think about construction in Baton Rouge, right? The interstate is going to get fixed a lot faster than the back roads. So we get the interstates fixed in the first few weeks, and then it takes a while, about 6 months, to fix the back roads. Once we get some of those back roads fixed, if nobody travels down them very often, then they're not going to get fixed. Okay, and so after about 6 months, that recovery remains pretty stable. What we try to do in speech therapy is access those back roads nobody travels down very much. And so we're really building those pathways to help build up the roads that get us to the interstate. When we provide treatment, we do multidisciplinary intervention, which means we do not work alone. We work with other speech therapists. So typically if someone has aphasia, they may also have swallowing problems, not always, but sometimes. And so not all speech therapists treat swallowing problems, so they may work with another speech therapist. You also work with physical therapists who are working either with handwriting or working on walking or using the arms because there might be weakness on one side or both sides of the body, or on the legs, or on the hands. There's occupational therapy that'll work on activities of daily living. That could be anything from brushing their teeth to getting back to work. And then you're also working with the medical team. Everyone is working to reduce social isolation and increase social participation. Strokes can be very limiting, and the more that we work on getting a patient comfortable with their deficits and working on the strategies to improve them, the more comfortable they can be with social participation. With that said, it means that we also have to work with family members. So, counseling the family members on the extent to expect on the recovery, how to communicate, and giving the family members different strategies in communication, which means we have to include them in therapy. They're not just somebody who drops them off and leaves, they have to know how to use the strategies at home. And then also working with self advocacy. This is self advocacy for the patient as well as the family member. So, the patient, can they communicate their wants and needs? And can the caregiver, who may dedicate a lot of time to taking care of that person, also advocate that they need time to take care of themselves? And then during behavioral treatment, we'll talk about something that's similar to scaffolding. Essentially, you're working from the foundations where you're selecting very specific stimuli related to the language domains. You have very specific responses that you're looking for, and then if the patient meets or doesn't meet that target response, then you give very specific feedback of yes, you did get that, or no, you didn't. And then over time, you increase that complexity. So they might start in that clinic room, naming a fork, naming a spoon, naming a knife, and then they might go to the restaurant and, oh, look at that, the waiter didn't give them a spoon or a knife, and so they have to ask for it. And then you can also teach compensatory strategies. So maybe sometimes they still can't think of the name for the spoon or the knife. Can they talk around it and describe the spoon? Or can they use a gesture to show what they need to do with the spoon? Or is there some other way that they can communicate? All right, so we've reviewed neurologically based communication disorders and how they're a result of injury to the brain, either in the cognitive or language areas. Specifically, we talked about aphasia, the causes of aphasia and the brain-language relationship, how we classify different types of aphasia, and then the assessment and treatment, which we're going to talk about further in class.